Thank you to the SAGES Program Committee for the opportunity to present our work. My name is Justine Chinn, and I'm a first-year general surgery resident. Today, I'll be discussing the impact of BMI on outcomes in veterans undergoing robotic inguinal hernia repair. Thank you. We have no disclosures. With about 750,000 operations each year in the United States, inguinal hernia repair is one of the most commonly performed procedures in general surgery. Although traditionally performed with an open approach, increasing efforts have been made to explore the risks and benefits of minimally invasive techniques. Previous research has shown that BMI is associated with a higher risk to post-operative complications in both open and laparoscopic repair. And when looking at laparoscopic repair, higher BMI has been identified as a risk factor for recurrence. More recently, studies have demonstrated that robotic inguinal hernia repair using a trans-abdominal preperitoneal TAP approach is a safe, versatile, and effective option, and therefore warrants additional study on the impact of commonly encountered risk factors such as BMI. The objective of this study was to determine how difference in BMI influences operative time, short and long-term complications, and rate of recurrence in a robotic TAP inguinal hernia repair. To evaluate this, we constructed a database of patients who underwent robotic TAP inguinal hernia repair performed by two surgeons between 2012 and 2019 at a Veterans Health Administration facility for retrospective review, with a total number of 304 patients. All operations were performed by fellowship-trained minimally invasive surgeons. Recurrence and reoperation for any reason at less than 30 days and greater than 30 days was assessed. These groups were divided into the following categories: under or normal weight with a BMI of less than 25 with 102 patients, pre-obese with a BMI of 25 to 29.9 and 120 patients included, and obese, or a BMI of greater than 30 with a total number of 82 patients. The results of the three groups were analyzed using pairwise comparisons using t-tests with Benjaminian Hochberg adjustment method, as well as Pearson's chi-square test with Yates continuity correction. Our significance was set a p of less than 0.05. Our follow-up time was a mean of 188 days in normal weight patients, 251 days in pre-obese patients, and 275 days for obese patients. The outcomes of 304 patients split into three aforementioned categories based on BMI were reviewed. The median age was 66 for the underweight normal BMI group, 62 for the pre-obese group, and 59 for the obese group. The majority of patients were male, white, ASA class 3, and the most common comorbidities included a history of diabetes mellitus and smoking. Demographic and comorbidity variables were not significantly different except for a high percentage of white patients in the underweight normal BMI group compared to both the pre-obese and obese groups. The average operating time of a bilateral inguinal hernia repair by BMI group was 83.5, 98.4, and 97.8 minutes for a BMI's group less than 25, 25 to 29.9, and greater than 30 respectively. Operating time was significantly lower in the underweight normal BMI group compared to the pre-obese group, with a p-value of 0.006, as well as lower than the obese group with a p of 0.01. When examining unilateral repair, the average operation length by group was 65.2, 70.9, and 85.6 minutes for each BMI group as shown, demonstrating a statistically significantly increased time for obese compared to underweight normal with a p of 0.001, and for obese compared to pre-obese, with a p of 0.01. There was no significant difference in short-term complications, including urinary retention, UTI, surgical site infection, hematoma, bowel obstruction, ED visit, readmission, or recurrence or reoperation at less than 30 days. Similarly, there were also no significant differences in long-term complications, including pain at surgical site at 90 days, retained cord lipoma, or incisional hernia, or recurrence or reoperation at greater than 30 days. This report contains limitations inherent to a retrospective cohort study, including the possibility of inaccurate, incomplete, or missing documentation. Variation in operative time could be due to difference in technique or experience between surgeons. Additionally, due to the small number of individual complications, it may be difficult to achieve statistical significance when an event may actually be clinically significant. Additionally, although this information may be generalizable to the VA population, it may not apply to the general population. In our study, BMI has a significant impact on the operating time of both unilateral and bilateral robotic hernia repair. Despite this increased operative time, BMI group did not differ significantly in postoperative outcomes or in recurrence rates. This information supports that robotic surgery may be a good option for patients with higher BMI. Thank you for the privilege of this podium, and I'm happy to take any questions.